morning, everyone, and thank you for joining us today. My name is Shael, and I will be supporting facilitation of today's Town Hall meeting. Before we begin, I'd like to acknowledge the traditional custodians of the lands on which we're all joining from today. I'm joining from the land of Turrbal and Yurruga peoples, and we pay our respects to elders past and present of the Aboriginal and Torres Strait Islander peoples as cultural authorities of the world's two oldest living cultures. I also extend that respect to all First Nations people joining us today. As we all know, workforce is a word that's on everyone's mind in the healthcare this year. It's a priority that has been highlighted by the new state government, and it's been the headline topic at the most recent Queensland Clinical Senate meeting. Across every region in Queensland, health services are grappling with staff shortages, long wait lists, and growing access difficulties, all while facing an ever-increasing demand for care. Given these challenges, today's Town Hall focuses on workforce issues and the impact they have on healthcare delivery in our state. Our discussion today will be led by HCQ's CEO, Keith Tracey-Patte, who will guide us through the results of our recent High Five poll, as well as feedback from consumers in the HCQ network. Without further ado, I'll hand over to you, Keith, to lead us through today's meeting.
Excellent. Thank you so much, Shael. And it's lovely to see everybody all online. It's been quite an amazing 8 or 9 months since I took over this role after the incredible work of Mel Fox and others before me. So I'd like to introduce myself to you and to acknowledge that how much I respect and value the input that this organisation has had in the improvements in our health system over the last 10 or plus years. So workforce, as Shael has said, is the word on everybody's lips. To give you a sense of some of those, I've had the opportunity over the last little while to meet with the Director General of Queensland Health, Dr. David Rosengren, and with the Minister. And this has certainly been one of the topics that's come up, both in public and private meetings. Just to give you a sense of the scale of some of the challenges facing us, and these are the numbers straight from the Minister the other day. It's estimated that Queensland needs to grow its health workforce by about 36,000 people by 2032 to match the demand for health services. And to put that in a sense of scale, the Minister has been saying that at the moment, health consumes about 1/3 of the state budget. And if we continue to grow the demand for health services and employ more health workforce across Queensland Health, they're looking that would end up being about half of the total state budget by 2040. And that is just an extraordinary cost. And that's something that governments right around Australia and around the world are all struggling with, because I think it's worth acknowledging that this is not just a Queensland issue. This is a global issue, and it's being driven by a number of things. Firstly, as our population ages, we have more people who are wonderfully growing older in our community. That does mean, though, however, that as we get older, our care needs increase. And so therefore, just having more older people in our community increases demand. The other thing, though, is that the workforce is also growing older, and that means that many of our workforce are looking over the next 10, 15 years at retiring. There's been some really interesting work done across Australia, both by the Commonwealth Government and the Queensland Government, looking at how you model the demand for workforce. And there's some really common stories that they're telling us. But I just think it's worth noting that one of the major things that governments are looking at, which is really relevant to us as health consumers, is there's a sense that part of the problem is that there are some real structural barriers to our workforce working efficiently and well, and in particular to whether or not people are able to operate at their full scope of practice. There's a growing sense that we need to not just have the existing models of care, but move to increasing use of multidisciplinary models of care, particularly in primary care. That is, I think, sensible and logical, and we've certainly done some work with our primary health network colleagues over recent months to talk about this, and I'll give you a bit of a summary of what you, our consumers, have told us and that we will be sharing with governments about primary health. Um, but I think multidisciplinary care and changes to scope of practice, we have to keep constantly reminding the health system that in the bid to find efficiencies and in the bid to find more and better ways to provide care, that we need to focus on safety and quality. And particularly when we're looking at rural health, it is never acceptable to start with where we don't have the workforce, so therefore we're going to reduce the level of care. Nobody says that openly, but there is a real risk that we'll end there by default if we don't keep putting the consumer experience at the center of every decision. So scope of practice, there was a major review conducted by Professor Mark Cormack just in the last year or so, and he has said a number of things about changing scope of practice, and the federal government is looking at implementing those. But one of the really interesting things in that primary care space is that Professor Cormack has really focused on, as we get older, as we have more people living in our communities with complex chronic health conditions, the current approach to the way that we fund GPs and the rest of primary care actually needs to change. As you know, most of us would go to a general practitioner, either be bulk billed or pay a co-payment as well. And we would generally see a doctor, and there is a single fee for that transaction. But there's a lot of evidence, and many of us have known this for a while, that that model doesn't work if you're doing complex management of, or comprehensive care management of complex chronic diseases. You actually need to have a different approach where you have a bit of a blended fund. That is, you have a primary care team who gets funded to provide care to you as a patient. What they're talking about is having that blended model, moving from about 10% of the current fee arrangements up to over half over the next 10 years. So if you are somebody who is assessed as having complex care needs, that means that you're likely to have the opportunity to be registering and participating with a primary care practitioner, usually your GP, and over time that these blended funding models mean that you would not necessarily have a Medicare bill each time, but what would happen is that you would get care throughout the year, and then you would only go to that sort of fee-for-service approach around if you had a cold or something episodic. So these sorts of funding models are not only being thought about by government, they're actively planning for them. So I think there's going to be a really, really important work for us as a health consumer network, not just here in Queensland, but across the country, to look at those changes and make sure that they really are about the consumer. As I said a little bit before, the big concern here would be in the drive for efficiency, that people forget that this is all about high quality, safe, affordable care for all of us. So I thought it might be worth sharing some of the great work that Shael and the rest of the consumer engagement team have been doing, and just give you some of the sense of the things that we are hearing about the health workforce, and particularly the work we've done with the Darling Downs and West Moreton, Brisbane North and Brisbane South primary health networks. So these are Commonwealth funded entities who've been looking at GP workforce availability. And there have been some really key themes which have come out every time we've spoken to the community about workforce. The number one is around access and affordability. We know that there are many places around the country where people are struggling to access their local GP. We know that many people are struggling to afford it because there are very few GPs who bulk bill uniformly. There was a report that went out recently that showed that there's been a regular reduction in the number of bulk billing GPs across the country, and that includes here in Queensland. And we know that there are some areas where people live with relative socio-economic disadvantage, so they don't tend to be high wealth areas, and there are almost no bulk billing clinics left. And that is definitely impacting on the affordability and people's ability to access care. And we know from some survey work that we did recently with our consumers that there are people who are choosing not to access care because they can't afford it. And that's including in houses where people might have multiple people with chronic health conditions. So the need to make sure that primary care is affordable and accessible remains the fundamental concern that we have about the workforce, particularly in primary care. So you've shared frustration about the need to travel further because of costs to, for example, access bulk billing. The need to make sure that there is good coverage for people with diverse backgrounds, First Nations communities, multicultural communities, and for the soft skills of the GPs to really recognise that diversity is another issue or another theme that's come out. The need for good soft listening, building rapport, making sure that GPs really understand you as a person, not just simply, the next in the queue is coming out. And of course, the workforce shortage exacerbates this stuff. If doctors are really facing incredible demand in their practices, their capacity to sit and spend time with you is impacted. So all of these things do tie together. And we know that you genuinely value the time and the care that the GPs put into your visit with them. And I know also from our conversations with GPs that GPs genuinely are committed to their patients, and they too want to have the time and space to have those conversations. Another issue which is coming up quite strongly is around the need for continuity of care. Why is it that every time you go in to see your GP, you're seeing a different person? You're having to tell your story again. Practice software should have most of the information, even if you're seeing a different person within the practice. But there's not necessarily the capacity within medical practices, or perhaps the funding models aren't driving the desire to have an approach that has really embedded continuity of care into those conversations. And we know that all of us value a long-term, stable relationship with the GP to build up trust so that you can have those difficult conversations, so that you can share the things which are going on in your life, and to build up a long-term plan which is then put in place for you and your loved ones. There was quite a bit came up too about the need for better collaboration between GPs and the broader health and community care systems around them in your communities. This is a bit of a theme of the multidisciplinary approach that I spoke about before. Sometimes your GP needs to be just one part of a broader team to provide you with the outcomes that you're looking for. It might be that you're better placed going out to see a physiotherapist or a dietitian or another allied health professional. And there's a growing movement across Australia at the moment to move into some things that are usually called social prescribing, where it might be that what you actually need is connection into your community. It might be something that's not medical, but it might be something which would have a big health and well-being outcome for you. And particularly as people are aging and more and more of us are living in our own homes rather than being in community, we do know that social isolation is definitely having an impact on people's mental health and broader well-being. So this move towards social prescribing and better collaboration with other health professions and other community care professionals is actually a really important part of our health response. And those workforces too are suffering shortages. So getting access to community nurses or getting access to physiotherapies and occupational therapists and others continues to be challenging and is likely to continue to be even more challenging. You've also made very, very clear in our work with consumers about the need for GPs to stay current, to keep their information and their understanding of care to be based on the evidence and to be modern, not just what they learned 20 years ago at medical school. We know that all of us, when we sit opposite a doctor, are very, very conscious of the fact that GPs are working a lot of hours. Medical practitioners more broadly are working a lot of hours. And we had some amazing consumers at the Queensland Clinical Centre the other day talking about this. And I remember hearing, we can see what goes on from the bed in the hospital. We can see that the staff are struggling. We can see the culture of the care from our beds. And that's the same as well if you're sitting in a waiting room in a GP's practice. You can see that people are under stress. And we know that all of us care about our health professionals. We care about the staff in the clinics and the staff in the hospitals. And we also know that very, very strong evidence that people can't provide high quality care if they don't feel safe and supported in their workforce. And one of the things which I have raised with the Minister and the Director General is the need to ensure that hospitals and the rest of the health clinics are places of safety and inclusion for the workforce as well, because we know that without that workforce feeling safe and included, they will not remain in that workforce and they will not be able to provide high quality care to us. So again, it's a really important theme and something fundamental to pay attention to as we work our way through some of these challenges. Financial pressures, this comes up really all of the time. We spoke about access to bulk billing. There is now quite a significant gap between the Medicare rebate and the price that most of us pay when we go to visit the GP. I think most recently it was up just over $40 for the Medicare schedule rebate, and the fee charged by the GP when I went most recently was about $95. So that is something that is definitely causing challenges for families, and we know that people are then sometimes making decisions based on cost rather than what their health needs are. That is concerning, and it is something that we within Health Consumers Queensland are really conscious of. And I wanted to let you know and the rest of our network know that we work very, very closely with the rest of the health consumer peak bodies across the country. So there's peer organisations we have in the rest of the states and territories. We also have a national peak body called Consumers Health Forum. And this is the number one issue that we are all raising with the federal government at the moment, is that the financial pressures and the risk that people will cease attending or not choose to go for important medical interventions or screening or vaccinations or other important parts of our health response. So this is the number one priority in our sort of lobbying and advocacy in partnership with our colleagues in the rest of the states and territories and in Canberra. We also do a fair bit of work and have done with the PHNs around what are the pathways for new GPs and other health workforce. One of those is that we are in the process of forming partnerships with a number of the universities in our state to look at the way that they train and support new medical and other health professionals, the need to embed consumer engagement into their understanding of how they operate, how they practice, but also what is it that a modern workforce would need, what's the training that they need, and how do they make sure that we address those areas of critical workforce shortage. I know too that the federal government is very, very focused on this particular issue. They've just released a paper about 18 months ago and are in the process of implementing some new GP workforce requirements to make sure that we have more specialist general practitioners in rural and remote regions. There are some really interesting mentoring models and supervision models which are part of that, to encourage people to not only go to rural regions but also stay there. And a fundamental part of that is also recognising that we need our local workforce to be employed in our local regions. There are some really, really great examples of projects which have not yet rolled out nationally, but we've seen, for example, some great partnerships between hospital and health services, employment network providers, and local community leaders to create job pathways so that people in a particular region stay in that region, access jobs there, and also have a career pathway within the hospital service. It could be something from starting in admin, getting some academic qualifications, becoming a health professional, staying there and being promoted. Not only is that a really great way to ensure you've got local employment, but it also really addresses one of the recurring problems we face in our system, that the health workforce is not reflective of the community's diversity. The more we can put in place and support people through these job pathways, the more we will have First Nations people and people from different cultural backgrounds and different genders all being part of the health workforce and being reflective of us as a community. It also really strongly addresses workload retention, because people do want to stay and work in their own communities. So if we can get more rural folk staying in rural communities, which is their intention and their desire when they start their training, the better place will be to manage the demand for services in those really thin markets, as they say in health economics. Another really interesting area, and which has come out in your feedback or the feedback of your colleagues, is about the importance of GPs listening to consumers. So some of you might know that the National Health Standards, Standard 2, requires health service providers to have a plan for how they will engage with consumers right from the design and the delivery of their services right through to collecting feedback. That has not been done to the same level of maturity in primary care as it has in the health and hospital services. Some of you are probably part of consumer advisory groups or boards or networks with health and hospital services. But there is a genuine desire to look at how you embed those approaches more fully into primary care. Last week, I was down talking to the Australian Commission on Safety and Quality in Healthcare, which is a federal body. And one of the issues that we were looking at is to include a better ability for GPs to capture this information about their own practice at a local level and embed that into the standards. So even though those standards don't commence until 1 July 2028, there's already a review underway, and we're actively involved in that review with our colleagues across the country. And of course, as always, a really, really strong focus on consumer psychological and cultural safety. How do we make sure that in this period of time where we're really likely to be struggling to get workforce there, that these are people who not only are clinically capable, but they are culturally capable. And that means ongoing need for investment, including through professional development and through communities continue to set expectations that there will be an understanding of what good, safe and appropriate care looks and feels like for health consumers. So that was quite a mind dump. So hopefully that wasn't spoken too fast or anything else. But just to let you know that the results of our recent health workforce high five, we know that this is a regular piece of conversation in your communities, that generally allied health professionals and hospital staff and GPs make up the vast majority of healthcare in each of your communities. We know that conversations around workforce are happening really regularly in all communities across our state. In this particular survey, what we found was that about a quarter of you were saying that health workforce is coming up all the time when you're meeting with your communities and your networks. It's coming up at least weekly for about 30% of you, and at least monthly for over 20%. So, this is an area of really, really strong interest right across our society. And the responses we've got from our recent survey are really, really reflective of that. The really critical challenges which you have raised with us around the capacity to access specialists and appointments in a timely way, particularly where you've got complex or chronic conditions that need ongoing management, and a pretty high response to around better access to services due to the workforce shortages. So whether that's physiotherapy services or other allied health professionals, as well as specialist services. And you think it would definitely be beneficial for consumers in our community to learn more about workforce in order to be part of the conversation. And that's part of what we are starting today, is how we can build that conversation.
Everyone, we're now moving to the live Q&A part of our session, and a big thank you to everyone who's already submitted their question. We've got one here from Gail. Is there any support for changes to private insurers being able to pay gap fees, in particular to specialist consultations, where this can be $200 to $400 per consultation?
Yeah, look, I think this is an area where we historically have not spent as much time, and I think it's something that the team and I have really been starting to talk about. Is private health insurance is what is it, about 30 to 40% of us have private health insurance. And what we're seeing is that the private health system is also under significant pressure. We know that increasingly, I think this year the increases in private health insurance rebates were about 11% on average. I also know from the conversations that I've had with a number of the private private hospitals, that they are under significant financial pressure. That's being driven by very similar things that are driving the workforce pressures, that they're struggling to get workforce, that the costs of delivering care are going up, and that the amount that they getting from private health insurers is quite constrained compared to the rate of increase in those costs. At the same time, of course, private health insurers face a real risk every time they increase their subsidies or, their premiums, because people just choose to leave. And so we now have a system where more older people who've been in private health insurance for a long, long time are remaining there, and fewer young people are choosing to take this for their families. That's putting incredible pressure on the private health insurers. So to go take that context and put it back to your question, we are definitely aware that there's significant pressure. I've been starting some conversations with the private health insurance peak body about what some of these things are looking like and feeling like for consumers. They're very aware of the affordability and the impact it's having on people's capacity to access the specialists of their choice, and to access the private hospital system more broadly. So we are in the conversation, but we don't have an answer, is probably the best way to say that, Gail. It is a huge and growing issue, and it's one that we are definitely stepping into.
Thanks, Keith. Another question from Patricia. Any feedback about internationally qualified health practitioners filling the gap in health workforce, especially in rural areas?
Yeah, it's definitely been part of the conversation. Um, the the pathways for overseas trained medical practitioners into Australia is definitely causing some barriers to their availability in community. In its review last year, under the Strengthening Medicare review, there was a workforce component, and one of the things that was recommended to government was that they really look to make those pathways easier for those who are very well qualified. But not in any way to diminish our acceptance of the level of skill and experience that we would expect people to have. And also to incentivize people who are arriving in our country to practice in rural and regional Australia. So that major government piece is definitely there. They're talking, last time I spoke with the Commonwealth government about this, they were talking about those reviews and the government's response to them coming out in about October this year. So we should have a bit more information. Queensland Health, when I talk to them, they are definitely thinking about the volumes of overseas trained health professionals, not just the medical practitioners, but the nursing workforce and others, as well, as part of their plan. But I think we have to also recognise that there is significant international pressure on those highly skilled workforce. This is not just an issue in Australia, it's an issue globally. And what we, I think, have to do is think about how we can be an attractive place for people to live and work. You know, the beautiful natural country we have around us, the safety that we have in our communities is really important. But I do want to flag in there, one of the things which comes up all of the time is the need to invest heavily in supporting those overseas medical practitioners in understanding culture. We do have, and I've just been part of a project where we were working with some First Nations communities across Queensland. And part of the challenges they were having in accessing safe, high quality care through their local hospitals was cultural misunderstandings. So we have to recognise that this is an important part of the workforce mix, but it does take investment and it does take time for people to become familiar with the Australian context and to learn to provide culturally appropriate care, particularly for our First Nations communities.
Thanks, Keith. We've got another question here. What is the best way for consumers to educate yourself and the HCQ team around past history that encompasses all of our long-term consumers learning through engaging in our communities and our lived experience?
Oh, look, that's a great question. We at Health Consumers Queensland as an organisation have been here for a long time, but the team is relatively new. We've had a period over the last 2 years where we've had significant turnover. It's a stable team. We're all here now, but we genuinely would appreciate hearing from our long-term network about those things which were predating our work. And I'll just flag one of those as something that we're actively working on at the moment. The incoming Crisafulli government has made a commitment to expanding maternity services across the state, to having the capacity for mums to deliver closer to home. In the process of doing that, we became aware that there's a real need to pick up and ensure that the great work that was done in between 2017 and 2020 with the Rural Maternity Task Force wasn't forgotten. So we've been able to pick up and dig through all of the records, and we've got some pretty strong positions that we know that we need to put to government around the need to plan this well and engage with communities really deeply in order for maternity services to be safe and really achieve what the government is trying to achieve with them. But we will absolutely be reaching out to our network and saying, we want those of you who've been around for a while to talk with us and to tell us what really matters to you, and also to make sure that we don't miss the lessons that we as an organisation have already learned several years ago. So there's a couple of things you can do. Firstly, if you know about something that's really important and you think that it's not on our radar, please send us an email to the info@hcq.org.au email address. The team is going to be actively monitoring that for quite some time to make sure that we can then decide whether we're going to pull small groups together and have a bit of a chat, or whether we can have some one-on-one conversations with those of you who've been on task forces or sit in consumer advisory councils or other things, to make sure that we capture that intelligence. The second is that we're going to look to try and create some communities of interest. So that if you've got a particular area of health interest, whether that's around data or oncology or rural and remote health or First Nations health, that we can create these little places where you can engage with each other and then bring us your collective wisdom, so that we can make sure that we're representing those views to government. Sitting behind what I just said there is something that I want to make sure that all of you know, is that when I first started in this role, I went out and spoke to as many people as I could and said, what is it you really want from us? And something that came back really loudly and clearly to me was that health consumers want us to represent and advocate. And so what we are in the process of doing at the moment is creating some position statements on the things which are current. Some of you might have seen that we released a position statement on the government's decision to cease new uses of puberty blockers and hormone therapies for children accessing gender services. We also are planning to release a workforce position statement, and that will be a piece where I absolutely want to reach out to all of you. So what we'll probably do is something like we'll draft an initial thing and then send it to everybody who's participated in this town hall and ask you to have a look at that position statement before we start to release it to the world. But I also had a conversation with the Consumer Collaborative about this. And what we'll probably do is pull together groups of little projects around specific high interest areas to have our position very, very clear, and also where there is something which is emerging in either Queensland Health or federally, or in private health, that we are positioning ourselves and very deliberately taking a position that is already well thought through and where we've already engaged with our consumers before we go and have the conversations with health decision makers. So it's a really important thing, and it's something that we're definitely going to be continuing to grow, pick up the things that we used to do really well, and put in place some new things.
Thanks, Keith. I've got a question here from Sarah, specifically thinking of mental health. We know the current workforce in this sector is completely overstretched. The current workforce shortfall is about 32%, but predicted to be 42% by 2030. We know that mental health now makes up 30 to 40% of GP caseloads. Is this still a priority for our governments, both state and federally? And have you heard anything around any plans to sustain and grow this critical workforce?
So I would say, yes, governments are aware of it. I don't think they've been paying as much attention to it as they probably need to. Mental health for many years in Australia has been a bit of a football between the federal and the state governments. The primary health networks have been doing some really good work in trying to map the service delivery of a range of things. But you've picked up on probably the biggest gap, which is that a lot of these health services are funded through Medicare. GPs are already stretched. Their capacity to provide continuous care to people with mental health lived conditions is definitely being impacted. The other thing which I'm really noticing is that there's a lot of stress on the peer support and navigate workers within mental health. There is a major review being done at the moment of the mental health agreement. And interestingly, that mental health agreement review is being conducted by the Productivity Commission, which is not generally a group that gets involved in health. But the reason they've been asked by the Commonwealth to do this is they actually want to look at more efficient and better ways to ensure that people have access to the health workforce. And so we actually met with the Productivity Commission a few weeks ago. They asked for our experiences, including the incredible work that was done around the Barrett Review by a number of health consumers with lived experience of mental health, that the need for consumers to be involved in every part of those reviews, the need for consumers to be involved in the ongoing delivery and planning for management was picked up. But what the Productivity Commission is actively looking at is, are there other workforce that are required to better support people with mental health conditions? We've got some big gaps between GPs and psychiatrists. That you've got GPs, psychologists, and psychiatrists. Some of those barriers around what unlimited number of sessions that you can have with a psychologist, that legitimate question to ask about whether or not GPs should always be the gateway to accessing those services, and are there other ways that we can provide support to people? So is there enough attention being paid? No, but is there some attention? Yes.
Thank you, everyone. We're receiving an influx of questions, so we'll try to get through as many as we can before we finish up. We've got one here from Sue. Have there been any discussions on helping communities with high cost housing and limited childcare to attract healthcare staff?
I haven't seen anything recently, but it is something that I have definitely been raising with ministers, because this is one where I think we actually need to get to the government itself rather than to health professionals, because we all know, anybody who's spent 5 minutes in a regional town would know that teachers and nurses and police form a really important part of the community, and often housing and childcare and schooling and other things are the reason that people choose not to go and choose not to stay. So I have been talking with the minister about whether or not he's prepared to engage with his peers across government to talk about some community building approaches. I think it would be very fair to say that they're not there yet. This is a government that's only been in place since October last year. They've got some really strong priorities, and of course the Olympics is one of them. But this is something which I think they need to address if they're going to really tackle some of the big, challenging, what we used to call wicked problems in social policy. But there definitely needs to be some community solutions. And one of the things I think that maybe we as an organisation might want to challenge ourselves with is, can we actually create the community-led solutions and then invite government to support them? Is there the capacity for a town like Roma to actually come up with a local solution and then go to government and say, if you could do this, then we think we'd be able to attract and retain our health workforce. So I'm absolutely prepared to go to the table with those solutions, because if we leave it to government, they will stay within their ministerial silos.
Final question for our session today. How can we help to raise the profile of HCQ?
Oh, look, that's a wonderful question. There's a few things you can do. Firstly, if you don't already, I'll start with the simple and we'll go to the more complex. Here we go. If you don't already follow us on social media, if you don't already subscribe to the e-alert, then please do those things. I'd also ask if you can share that with your friends, your networks, your health consumer colleagues, because the more that we can share this information, the more we can build. We also know that we need to do more to provide support to you. One of the things that Shael and the rest of the consumer engagement team will be spending a lot of time over the next 12 months to 3 years is building and diversifying our network. So we'll be actively reaching out to communities. You will have seen some things like our Coffee and Connect. You will have seen some opportunities for different projects and different ways of engaging with us, whether that's through webinars and town halls or whether it's through local projects. And what I would love for all of us to do is to get into the practice of each time we do something like that, that we invite people to be part of our network. It's a nice, simple thing that every one of us can do. So share the information we provide, encourage people to subscribe, share our social media, and then don't be afraid to talk about us. You know, when somebody describes to you that something that's not worked in their health journey, don't be afraid to say, well, why don't you join Health Consumers Queensland? I would love to hear about your experiences. One of the things which we are reinvigorating this year is that we know across the state there are many people who are involved in consumer advisory councils, consumer advisory boards, consumer advisory networks, consumer advisory groups, who are engaged as advocates in different places, whether it's mental health, lived experience, disability advocacy, or maternity services. What we would really, really like to do is to encourage people having conversations with each other and providing that intelligence back to us. So we'll be reconvening some of the chairs of CAGs discussions to make sure that the health and hospital services and PHNs across the state, that we're hearing what the burning issues are so that we can take that fearlessly to government and decision makers in the health system. When I was talking with the Director General recently and about us as an organisation, and he knows us and he values the work that we do. But what I think health systems, particularly hospitals, often fail to appreciate is that the power dynamics mean sometimes their staff aren't safe to tell them the things that they really need to hear. And that's where we can really step in. So if consumer advisory councils are all hearing and seeing the same things and sharing that with us, we can advocate for change in a way that is a little easier for us to do than perhaps people can do straight up and down our governance framework. So there's a few simple things, but we also know that we need to make sure that we're supporting you with those and communicating even more with you than we have been.
Thank you. Thanks, Keith, and thank you, everyone, for submitting your questions. If you had any questions that didn't get answered, please feel free to email them through to info@hcq.org.au. This brings us to the end of today's town hall meeting, and a huge thank you to you, Keith, for sharing these valuable insights, and to everyone for joining us today.